I'm very, and I'm very grateful to Medvantage for giving me this opportunity to speak upon the topic. So let's switch on to the topic straight away without wasting much time. And that's it. Starting the slideshow. There you go. Right. So that's what the topic is. So I just opened it out. It's optimizing graft versus host disease mitigation. कैसे GVHD घटाना है मुझे in allogenic stem cell transplant. See, there are plenty of transplants that go on. We take on plenty of transplants. One is allogenic, one is autologous. We take xenografts, though it's a very small subset. We take isografts if you are very lucky. But this is one particular part, allogenic stem cell transplantation, which we often perform. And the topic out here is for myelodysplastic syndromes, MDS. Now, MDS usually they do progress to AML. That's the common literature. So MDS is a process. Just give you an anecdote. It's a process where hematopoiesis is very rugged, and we don't get adequate cells out there. So we get immature cells, and from there we get blasts, and it's got a very poor prognosis. Around 40 to 50% of the patients, they usually progress to AML, and of course treatment is extremely difficult, and at the same time we don't have much options out here. So this is what actually made me think about this particular topic. And the biggest complication that we have is GVHD. Now, there can be acute GVHD or chronic GVHD. Acute GVHD is around, it goes up to 16% and comes within 3 months. Whereas chronic GVHD will come after 3 months with a larger bit of complications. And even in today's day, I have said a bit of the statistics. It was 16% for acute GVHD, and even in today's day, with a lot of improvements in therapy or in therapeutics, you get almost 70% of that. It becomes very difficult to treat. So that is why this entire thought came out in my mind, and let me switch on. So what are the keywords out here? The keywords out here are graft versus host disease, mitigation strategies in allogeneic stem cell transplantation. Let's forget about MDS and AML for the time being, because these are blood cell dyscrasias. So this is the goal of the entire thing. Optimizing graft versus host disease mitigation. How to reduce GVHD. Right. So this is the background I have already said about MDS, and it goes on to become AML. Post-transformation, we have very high mortality. Once it goes to AML, acute myeloid leukemia, it's got a very high preponderance of having a big time mortality. So as of now, we have allogeneic stem cell transplant. We have better options in the US, the UK, and the Western, but that's still under process. Well, the next one. So what's the dilemma? So this has been discussed, the graft versus host disease, which is the major cause of mortality and long-term morbidity as well. The next one, this becomes very, very important, graft versus leukemia, or we say graft versus leukemic reaction. This will actually help the patient, where once you transplant, the set of cells which are harvested from any place. It can be from the patient, which we call autologous. It can be from a haploidentical person, which can be a first relative or something like that. It's called allogenic. Xenograft, as I told you, it's a very small subset where we get we harvest from different species, and if enough, hello, yeah, and if we are, am I okay? Is it all right? Hello, hello,
Yeah, okay, sir.
hello, yeah. So should I continue? Hello?
Yeah, continue, sir.
Yeah. So the last part, the isograft part. Isograft, if we are very, very lucky, then we can have one of them. When I speak about isografts, you should keep it in mind that we need to have we need to harvest it from a donor, right? We are usually harvesting from donor. We can harvest it from the person itself. We can harvest it from some other species, and also we can harvest it from an identical twin. Now, what is an identical twin? That's a very important part. They're known as monozygotic twins in the process of fertilization. If a sperm goes and fertilizes a single egg in a single pregnancy, and if two zygotes are there, I mean a single zygote is there, and we have two babies from there, so they are completely identical. So in those cases, yes, people are very lucky. So that also goes to a very small subset. So right now we practically use allogenic stem cell transplant as far my experience is concerned. Well, the next one. Okay. So after a transplant is done, both for blood cell dyscrasias and for solid organ tumors, after a transplantation is done, we usually prescribe calcineurin inhibitors and methotrexate. Now, when I speak about calcineurin inhibitors, those names are very common. It's cyclosporin, it's voclosporin, tacrolimus, sirolimus, and all of this, they go and stop the notorious interleukin 2, that's a cytokine, and that is responsible for the acceleration, the logistic acceleration of GVHD in a patient who is receiving the transplant. So it increases the chances of mortality to a very, very great extent. That's the problem. The next one is MTX, in short, methotrexate. Now, when I speak about methotrexate, what does it do? It simply goes and attacks the enzyme. This particular enzyme, what is it called? It's called dihydrofolate reductase, DHFR, and it stops purines and pyrimidines. So if we stop purines and pyrimidines, what happens is we do not get, pyrimidine and purine analogs, and the replication of the tumor stops because there is no DNA RNA synthesis. But let me clarify on this part. This is a very outdated procedure now in today's day. We are and we will be looking for better procedures, and we are all also into it from various parts of the country, and of course, US and the UK have really accelerated this part. So on this particular part, that's how it goes. This is an outdated one. We don't use this right now, and if we are using it, so we might have issues which are delineated out here. It's non-specific immunosuppression. Non-specific immunosuppression can kill anything. Increased infections, reduced graft versus leukemic effect, and there's poor chronic GVHD control. The dreaded part. Post 100 days after the stem cell is being transplanted. That's the problem. So how do we solve it? There are 4 pillars. Today, in today's webinar, I'm going to speak extensively on in vivo T cell modulation and post-transplant pharmacology. This is important. Now, if I start talking about the ex vivo part, the ex vivo paradigm, ex vivo craft engineering, and this webinar is not going to end. So let me just focus on this too. In vivo T cell modulation and post-transplant pharmacology. Because in vivo means something which is happening within the body. As simple as that. Ex vivo is in the labs. That's it. You need to be very precise and clear with this particular concept. And I'm trying my level best to make it keep it down as much as possible because it's a very high-end topic. The goal is, of course, precision immunomodulation. So that's a different issue. Right. There you go. So what are the objectives? Number one, balance GVHD and GVL. GVHD kills. GVL actually is good for the patient. So to bring out a balance in between the two, which is a very big challenge in today's day. Number two, I will be speaking about this comparative effectiveness across donor platforms. This is another very important part. I'll speak about it later on. Third one is, come on, it's for MDS to AML. I can also bring in solid tumors out here. So that's not a problem. That's not an issue actually. So what I've done is that I've scrolled through PubMed Central, Euro PMC, and the Euro PubMed Central and the BMC, and I have figured out a study pool which had included 276 studies, from which I have selected 15 of them. There were junk studies as well. Even in this particular part, I'm noting it down in the paper, junk studies. I shouldn't be using the word junk, but still, let me use it for the time being. Now, what are junk studies? I will come to it. And what you should be avoiding when you are actually trying to formulate a hypothesis or a thesis, whatever it is, or a research strategy, or a treatment strategy, whatever it is. So, what did I include? I, of course, included the allogenic part, allogenic variety, and GVHD was reported out there. So, that's it. The reasons why I have excluded autologous, that the cells are harvested from the patient itself. Number one, xenografts, a very small subset, and isografts, people are very lucky if they have it from an identical twin. That's how it goes. Okay, so the next slide, this is the Prisma framework, the 2020 framework. You will, whenever you design a study like this, a systemic review or a systematic review, right? That was one that was conducted by one of my colleagues. Systematic review, you need to go for this particular part. What do you do out there? What are the databases that you take? You see, I have taken PubMed Central, Europe PMC, PubMed Central. There were duplicates and stuff. And finally, I came down to 15. This is not important. This is just a very simple slide so that you follow this. There's a tool for this, hackathon tool. You can use that and put your inputs. They will generate a photograph for you, depending on identification, screening, and the inclusion part. Inclusion. You can see I've included 15 studies out here. Right. So there we go. Data extraction was based on all of this: the donor type, the conditioning intensity, graft composition, prophylaxis, immune reconstitution, relapse and survival, and acute and chronic GVHD. I will be speaking on this particular part, conditioning intensity, later on, just around 2 to 3 minutes, after 2 to 3 minutes rather. There we go. So we had key results that yes, it did reduce GVHD and it did preserve GVL. Forget about this part. This is not important. All right. So now I would like to go back to my previous slide. I was speaking about conditioning intensity. Now you see this part becomes slightly interesting. What exactly happens? So you may imagine that a patient is there and a donor is there. Let's make it simple. So what we do is that there are 4 methods of transplant. One earlier method that people keep on using is, drilling through the iliac crest of the donor. They take out almost 1 liter of bone marrow with rich stem cells after, of course, HLA typing, and of course the other things that are there. HLA typing becomes very important, and CMV screening, cytomegalovirus screening, all of that and all of that. So what they do is that they drill out all of those stuff and then they go for the procedure. But there's a better thing out there. All of you have seen what BT is, or simple blood transfusion, right? So if I bring in an analogy to the entire thing, a BT, a simple blood transfusion. So what we do is that we take the blood from the healthy donor after the matching and stuff. We take the blood simply, and what we do after that, we condition it. The first process is conditioning, or harvesting. Of course, is the first part. We harvest it, and then we harvest the blood. Let's go for the blood part. Drilling through the iliac crest makes it very difficult and murky for the donor. So let's go for the harvesting part. So we harvest the cell. We harvest the cells from the bone marrow, not from the iliac crest, to get the stem cells from the bone marrow, healthy stem cells, right? Then we go for conditioning. Now this is the most important part, conditioning, and where my studies have skewed from this part, differed. Now in conditioning, what we do is that we provide cyclophosphamide to the patient. That's, of course, you can consider it as a chemotherapy or oncotherapy, whatever. The nomenclature wouldn't matter. So we provide cyclophosphamide to the patient. Along with it, what we do is that we go for radiotherapy. Why? To create a free blank space within the recipient so that I can infuse better cells out there. Let me come back to the harvesting part. If we are going for a PBSCT, peripheral blood stem cell transplant, instead of drilling into the iliac crest, which sounds very horrific actually. So there we ask, what we do is that we provide GM-CSF, granulocyte, monocyte, colony stimulating factor, and then we count the CD34 cells and the mononuclear cells out there, the macrophages out there. That's how we go, and we check the quality of the cells in harvesting. Then we move on to conditioning. I have just spoken about conditioning, where the recipient is being treated with cyclophosphamide, which is a very commonly available drug, and radio. Then we proceed for the transplant, as simple as that. And post-transplant, what happens is we have engraftment. And what is engraftment? It's a very simple thing. Once we harvest the cells, or once we harvest and transfuse the cells, in engraftment, this particular stem cell cohort, the better one, the good guy, is going to produce a lot of good cells out there, better cells. That's called engraftment. And then comes the dreaded part, the immune reconstitution. This is the part where we have either acute, within 100 days, we are going to have acute GVHD, or we are going to have chronic GVHD. Right. Please remember one point out here, that is cyclophosphamide, which has been given to the patient, the recipient, during conditioning regimen. This becomes important. Right. Forget about this. So this is the mechanism of cyclophosphamide. It goes on to eliminate T cells, preserve cellular T cells. I'll talk about it and some outcomes out there. So that's all right. Okay. This is what I found out in my study. The ATG strategy, anti-thymocyte globulin. Now, this becomes very important. How does it become important? How does it skew off from my study, differ from whatever I found out in various databases? You see, this is a this is one thing that we can add on to the existing regimen, the anti-thymocyte globulin. We can inject them. So around that, initially the doses were very high, but right now in phase 3 trial, they're saying that 2.5 milligrams per kg for 3 to 4 days. If you are able to inject this anti-thymocyte globulin into the patient during the engraftment procedure or post-engraftment for 3 to 4 days, I believe that's going to bring about a lot of reduction in the GVHD, and it's going to increase the GVL, graft versus leukemic reaction. This is one part. Of course, there are some risks, infection, dose-driven relapse signal. Yes, there are infections. Everything comes with some price. That's not me. That's some big scientist who had spoken up a long time back. So we do have problems, but this is one which might mitigate. I will prove it statistically after some time. So this is what basically happens. And what does this cyclophosphamide do if we transplant it, or if we transplant to be specific, if we inject it later on? What does it do? It kills. It basically goes and kills some specific cells which are notorious. I will come to the specific cell part. It's very important. If I say now, basically for GVHD, we have this alpha beta cohort, alpha beta T cell cohort, which is very notorious. We have a gamma delta T cell cohort, which is beneficial. And therefore, we need to preserve the gamma delta part, of course, and kill the notorious part. Same time, at the same time, NK cells, the natural killer cells, we need to preserve them as well. So this is what becomes very important. So the take-home message is, you kill alpha and beta. So lives are called alpha, beta, and gamma. That was there in one line in Three Idiots, I believe. So it's alpha, beta. We kill alpha, beta. We preserve gamma and delta, and the natural killer cells. That's the point for ATG strategy. Same goes for cyclophosphamide. I have said this a long time back, that cyclophosphamide was injected or it was given during the conditioning phase to the recipient, so that it create a blank space. That is a standard procedure for allogeneic stem cell transplant. But let me tell you, this is the point where my studies have differed, or my part or our part was differed totally. Cyclophosphamide must be given, as far as I have seen, must be given post-transplant, post the procedure, or post, say, engraftment. Yes, that is the point, the checkpoint where you need to put. So it is PTCy, you can see it, post-transplant cyclophosphamide. That is why I've used this particular abbreviation. At doses, of course, initially it was 50 milligram. It was actually 100 milligram per day in divided doses, 50 BD probably. Now it has come down to 14.5 milligram per day. Again, for in day 3 and day 4, I believe. Yes, that is what it is. We give it later on, not earlier, not before everything is done. We give it later on, not in the conditioning phase anymore. We give it to the next phase, that is the engraftment phase. This is also going to kill and kill. This is going to kill specifically. Specifically, it's going to kill the alpha, beta, gamma, delta, and the NK cells. And the doses, the phase 3 trial says around 14.5 milligrams per kg per day for 3 to 4 days in divided doses, of course. That sums up. Right. So the next, ex vivo. So I'd start with ex vivo. I don't finish it off. See, in ex vivo, what we do is something called CAR cell therapy. Now it's T cell therapy. The two parts. Now, if you speak about CAR, chimeric antigen T cell therapy, that's a big time thing. It calls for ex vivo, graft ex vivo. We take out the the cell. We take out the cells or the graft proper from either the donor or the recipient, and then we genetically engineer it. It's a huge procedure. We engineer it, keep on engineering it. There has been a huge lot of studies regarding CAR cell therapy. I have my own papers on that. So what we do in this case is basically what CAR does. CAR therapy usually it goes and hits the surface antigens of the tumor cells. Think it in this way: we have taken it, we have engineered the cells, now we are transfusing it to the diseased person, right? So we need to engineer the cells, and what it does, it goes and targets the cell surface antigens. So I'll name a few, and a few interesting ones as well. Say CD20, 22, 19. They are for B cell AL, acute lymphoblastic leukemia, the B cell type. We go for CD30, which is for Hodgkin's. We go for 33 CLL1 for AML. We were discussing about AML just a couple of minutes ago, I believe. So we go for that. And there's CD5 and CD7. Now, CD5 and CD7, I will just discuss this in short. It's pretty interesting. We actually engineer them and train them to go and try to train other cells to do a better job. To be very frank, it acts as a catalyst. That's the beauty of CAR T cell therapy. It's another one, the T cell therapy. Now, this T cell therapy is a different thing. This is a totally different thing. It goes inside the cell, totally inside the cell. Goes there and acts. Of course, we need to have a MHC matching out there, major histocompatibility complex matching out there, and then we need to work on it. So these are two therapies which are being discussed almost every day. I see 1 or 2 new posts in LinkedIn. I keep on sharing them. I keep on studying, reading, and there are plenty of stuff. I am saying that this webinar is not going to end if I speak about ex vivo stuff, ex vivo graft engineering. So that's how it goes. And what to add to this? This CART and CERT is going to, of course, change the entire paradigm. At one point of time, you're going to have no GVHD, maybe. That's the ideal part. And we might have better success rates, of course, but still it's under the procedure. It's under the lens, it's under the lenses, so it's going to take a lot of time. That's how it is. Right. Next part. So if I speak about cord blood, umbilical cord blood, of course, that we keep preserving these days when newborns are born, I believe. It's a very common concept. If we're having a newborn, we preserve the cord blood. cord blood is something which will give you a subtle amount of GVL, graft-versus-leukemia, the better one. But as far as GVHD is concerned, it is not up to the mark. I've seen plenty of studies, and it's not up to the mark. It gives a subtle amount of GVL, graft-versus-leukemia reaction for the patient, where post-transplant the cells go out there and help instead of destroying the good cells, right? So if I go for a transplant, what the T cells are going to do is that they're going to kill the tumor cells. They're going to kill the other good cells as well. So all are not bad. It's like that part, that too many. There's one rotten apple in one set of apples. So you need to kill that one rotten apple out there. If I explain GVL properly, so you need to kill one rotten apple. But what happens usually? Post transplant, they kill off all the apples. This is where the things go wrong. That's how this cord blood transplant is. That's one part of it. Though I'll not put much focus on it. It's not that important. Next, right? This is where my study or our study starts, and this is where you need to put the focus on. You see, this is a scatter plot, of course, and I have smoothened it logically with a loss curve. You can see the loss curve. Yeah, this is the loss curve. This curve is a loss curve. Divided this into 4 quadrants. It looks very self-explanatory. The x-axis is non-relapse mortality. Now, what do you mean by non-relapse mortality? So we almost excluded the part. Say we are discussing about MDS, myelodysplastic syndrome, which has progressed. It has progressed to AML. So right now there is no relapse of AML. We're simply talking about complications. That is why on the y-axis I plotted non-relapse mortality. Forget about the x-axis. So you can see the bubbles. So it was a systematic review. So what I've done is that I've plotted this properly. This portion you can see, it is post-transplant cyclophosphamide. The red one, I believe it's ATG. This again is ex vivo engineering, and you see on this portion, on the lower left quadrant, you get the most ideal performance. The flow GVHD, you can see all the green dots out here. So to work a lot on ex vivo, and that's not my topic today. I'll speak about ex vivo if my advantage allows me in some other time. So let's focus on this particular part. You see, I have said the post-transplant cyclophosphamide is the most is a better option. And it totally shoes off the previous literature that we knew that during our hematologists keep on doing, that we need to actually use cyclophosphamide for conditioning regimen, right? So here I have changed the entire course of the study. Then it's cues off. So give it later on, post-transplant. So ATG will fall in this quadrant, but not up to the mark. It goes up, it goes up, it goes up, it goes up, it goes up to many other quadrants, or also the high mortality rate. The upper right quadrant, right? You can find these dots as well. So cord blood will find their place somewhere out here. It's not that important. I've said it before. Read many papers, many studies. I have attended a lot of webinars, and cord blood usually do not work. They give you a very small amount of benefit. Now, this portion might as well, kind of complex things up. The mixed registry. Now, when we perform a systematic review, there we need to include people from every place on this earth to get a proper and a good result. Say, around 2 days back, I share one of my experiences as an anecdote. I was going through one of the papers in New England Journal of Medicines. It was we published in 1812. It's one of the oldest and most prestigious journals in India, in the whole of the world. I'm very sorry, I beg your pardon, the whole of the world. So they were speaking. They're speaking about a trial called a SMART trial, which was performed only in South Korea. And what they found out was that beta blockers post-MI, we need to just put it for 1 year. And after that, we can just throw off beta blockers. Now, how does a trial which has been performed in South Korea can be extrapolated in India? That's not possible at all. Of course, because we have joke for a small time joke, we have a big waist circumference, huge hip to waist ratio, right? Good arm circumference. So we do have a lot of comorbidities, and it depends on the ethnicity of the patient, the genetic framework of the patient. Now, we are not South Koreans or North Koreans, right? And of course, we are not North Koreans, so we are very lucky, I believe. So, jokes apart, you see this mixed registry. This is where the study has a lot of problem. This part. So, you can ignore this part actually, or you can take them into account. And if you start taking them into account, you are going to run mad, and that I can guarantee you, because you see, the studies here usually I've seen high-end studies being performed in Japan, or maybe of course in Japan, in China, in America, in Europe. There we go wrong. They take their cohort. They do not think about Indians. That's the worst part. Anyways, there's another problem, another stuff out here. You can see the size of the bubbles. This bubble is small and this looks big. Let me compare two bubbles, or maybe this two, right? So I've taken 15 studies on various parameters. Of course, the parameters are there. Post-transplant cyclophosphamide, the anti-thymocyte globulin, the ex vivo stuff, and also the mixed registry or the goblet as well, and plotted in the loss curve. So you see, this also indicates heterogeneity. If this is indicating a heterogeneity, this also indicates heterogeneity at the same time. In one study, they found out the potential of PTCy, or post-transplant cyclophosphamide, to be this much. The small bubble will indicate the power. And in one study, they found it to this part. That's where it is. Anyway, to simplify things, from this loss curve, the take-home message, and from this particular graph, take-home message is PTCy, post-transplant cyclophosphamide must be injected to the patient post engraftment, or in easy words, post-transplant. Once the transplant has been done, then you inject, not before that. And that too to the donor, not to the donor, and to the recipient, not to the donor. Right? That's how it goes. Right, the next one. Next curve. This curve, the standardized transplant exposure score, that we call the Z score, and the predicted probability of clinically significant GVHD. Self-explanatory to some extent, but you see, it does not follow a linear pattern. It follows a S-shaped curve. It's one point that I've marked. This is the point of maximum clinical leverage. It has been pointed out. Now, if we start with all these strategies, cyclophosphamide, about anti-thymocyte globulin, and rest all that I've discussed, is if we start at this point, the incidence of GVHD, the probability of GVHD comes down by 50%. 50% is a big term. If you have 100%, it comes down by 50%. You can see it's around 0.5 out here. So made it in decimals out here, but then it comes around at this part. This. And it's Z-score 1. It comes out at 50%. So we are bringing it down from 100% to 50%. This is the point where we need to work on. It becomes very important. Or what happens if we do not work on out here? This is of course the high risk zone. This is the low risk. Of course, it depends. It depends on plenty of factors. It's multifactorial. See, the chances of an increase in the odds ratio of GVHD goes up by 3.32. That's what it's written out here. One standard deviation. It goes up by 3.32 chances, the odds ratio. So that's the problem. We need to hit at this mark. I believe there will be a question why I have made a gray area out here. It's a very important question. Well, this also do indicate heterogeneity. This heterogeneity is killing of all the studies. You cannot make a single study in a single country or in a single cohort of patients, and then you suddenly extrapolate all of them. No, I cannot do that. That is where I believe that, and I had included in my paper as well, we are actually not getting the right part. It's because of this heterogeneity when we go for a systematic review or a meta-analysis. So this is where the problem lies. But then at the end of the day, this is the point, the take-home message would be, this is the point where we need to focus on. It becomes very important. Right. So this is a very, very subtle, non-important graph. The study characteristics. These are the studies that were taken. The maximum yield that I have got from study 4, right? Non-relapse mortality burden. You can see it. It's self-explanatory. So study 4 was much better, I believe. And the rest of the study is fine. They had their own viewpoints and all. Study 4 probably had less of a heterogeneity component, and yes, they were talking on better terms, to which I personally aligned, and I've taken up this study, this particular one. So this is a very this is a very unimportant part. It's from my end, right? So, with all due respect, researchers from all over the world, or maybe in India, they will have a better study outcome, maybe. But then I really worked hard. I had to go through 276 databases, and then I had to bring in and exclude and stuff like that. So of course, it brings in a bias part as well. That's what it depicts, right? Then, so I've said about the limitations. The first limitation is study heterogeneity. Number 1. Then it goes to mixed populations, of course. Mixed populations. Variable GVHD definitions. The GVHD definition cannot be variable actually. It has got just 2 parts. I've said it, repeating it once again. It's within 100 days, it's acute GVHD. And what happens in acute GVHD? We'll have lesions in the torso, skin lesions. We'll have problems in the liver and the GIT. That happens within the first 100 days. It's very alarming. It's high mortality, also in chronic GVHD, which comes after 100 days and which is even more fatal. Like, along with the 3, the liver, GIT, and the skin, we have the mucosa, oral mucosa, as well as the genitalia as the patient who had received the transplant, not the recipient rather. That's how it goes. So it limits. Has got a limitation detected, and I believe every study has limitations, and every author or a speaker must speak about limitations, the limitations of the part, limitations of the study or the part. That's how it goes. Okay, so what are the conclusions? I have said it. Ex vivo. Ex vivo will be in some other day. Let's speak about cord blood will also have a niche role. Doesn't matter. It's post-transplant cyclophosphamide. After transplantation, what you do, what we exactly do is that once again I repeat, 14.5 milligram per kg for 3 to 4 days. Or it was 12.5, I believe phase 3 was 12.5 milligrams per kg per day. Post-transplantation, and it's going to yield you very good results. It's going to kill off specific cells that I need, the alpha and beta cells, which are very notorious, of course. ATG, selective utility, I have explained this. And what the future. You forget about all of this, MDS-specific RCTs, standardization, immune profiling, precision transplant. I've written this, that's all right. Transplant algorithm is the third point. Precision transplant algorithms. You know what? At the end of the day, ex vivo, can have my word for it. Ex vivo graft engineering is the only future. It's evolving with every passing day. Or rather, if I be very specific, it has evolved to a very great extent. So that's how it goes, I believe. Once you have that part, I believe the curve that I've shown you, set point, which corresponds to around 50% of decline in GVHD, the curve, that particular red part, this curve. Let's go back. This, where was the curve? This curve. You know, this particular thing is going to go down. Where is it? Yes. This is where it is. It's not there. This is where we need to strike, and that is why I'm focusing much on this graph, this point. Let me know. Do I get at this thing? No. I believe I can increase the slide size. Yes, I can zoom in. This part. This part. It's gonna pull it down. So now, from my studies, from my research, it brings down to 50%. So there may be a day when, it will come down to out here with ex vivo engineering, right? And they're working on T cells, and other cells as well, and specifically on T cells actually, T cell therapy and CAR T cell therapy. So it's going to come down to here, maybe here, or maybe sometime on some very good day, on one fine day, get up in the morning and you get the good message that yes, it's absolutely curable. So I was in this one, right? So this is it. Some technical problem with this slide. It's all right. So this was what I had to tell you. Right now we have only the allogeneic part. Autologous, yes, it's good. The xenograft, small subset, and ISO, you're very lucky. Now, let me just add on a few things until I scroll down the slides. We just add on a few things, and that would be say on ex vivo. Let me just add on a few points on ex vivo. So, what happens in ex vivo? Ex vivo for CAR T cell therapy, CAR T cell therapy. You pull out the cells out there. That's excellent. And they target surface antigens. That's the part. So if they target the surface antigens, we need not, or we might as well avoid MHC, major histocompatible complex, or HLA typing rather, to be very specific. Might as well avoid, but depends on the source where we are harvesting. For CAR T, where we are harvesting the T cells, Or harvesting the entire graft, we are taking out the T cells from there, from the recipient. If you take it from the recipient, it's good. We can also take it from the donor, and if you take it from the donor, we need to actually go for the other procedures. We need to check on the other issues and all that. So there are plenty of things that keep on going around, I believe. And as far as T cell therapy is concerned, CAR T looks better than T cell therapy. That's how it is, because T cell therapy is very tenacious. That's the word that I like to use. CAR T looks better on ex vivo engineering. So that's what. Once again, I come back to this slide. It's the post-transplant cyclophosphamide and the anti-thymocyclobilin strategies and ex vivo graft engineering. I have said about this. Some other day, maybe I will speak on this part. And there you go. So I was invited for this particular thing on a scientific meeting in Ljubljana. Was it Ljubljana? Yeah. Ljubljana. That's how they pronounce it in Slovenia. Right on May, but I couldn't attend due to the Middle East conflict. On this particular meeting, the EHR, I'm a member of EHR, I'm a member of EHR, European Hematology Association scientific meeting. I was invited out here, but I couldn't reach. Probably they could have formulated a few more strategies, and I could have placed it out here for, of course, my ex-Stallman colleagues who are out there in this webinar. I cannot see them since I'm sharing my screen. So this would have been one part. Okay, and so that's me. You can scan me from the scanner. It's not a GVL barcode, it's my LinkedIn barcode. You can scan me from here. And once again, I would like to thank Medvantage for allowing me to speak. And presently, I'm a fellow of critical care medicine, which I have opted from Advantage. It takes on an online course and also hands-on at the same time for 12 months, 1 year. And it's actually Medvantage solutions, right? So probably Medvantage will, me and Medvantage may sometime bring out a solution in the days to come. And of course, it's powered, the fellowship is powered by NHS and the RCP. It's a very good fellowship. You can opt for it. Go to the site, see, and opt for. So that would be all, and to the pleasure, gentlemen, ladies and gentlemen. That's how it is. So I finish off with my slideshow and return to the Zoom part for a frank question answer session, Q&A session. That's how it goes. So yes, is a moderator there? Sir, are you there? Hello?
Yeah, sir.
Hello?
Yeah, sir.
Yeah.
Thank you so much.
We can go for a Q&A session. You can place your questions. And the questions need to be difficult. Let me put this part. Which perplexes me. So a Q&A session, please. Any questions from people who have joined? Anything. You can ask me anything and ask me to go back to the slide part. If you've got some problems, some questions on there. Anything. Any questions? The the host is there. Sanjay sir, I believe the host is there. The host is going to.
Yeah, sir. I think there are any more questions. So,
They are. I'm not getting you, sir.
yeah, I'm saying that they have no questions.
They
So,
have no questions. All right. If they have no questions, I thought they might also have questions, because this particular topic, they might have questions. Okay, that's how it is. So that's all right. If they do not have questions, then what should I do? That's up to you if you can come to the meeting. Then in that case, let's give them another 5 minutes, I believe. If they can formulate a few questions for me. Any questions, my dear colleagues? Anything related to transplant, the procedures, or maybe I was not that eloquent, I believe, or fluent, because this is a very, a very diverse topic or something like that. So if you can ask me a few questions. Okay, no questions then in that case. So could we end in that case? I sincerely thank the moderator. I sincerely thank my
Yeah, sir.
advantage
Okay, sir. That's not a
when you
problem.
welcome me,
Uh,
and
Session is very good. And thank you so much for your session.
thank you, thank you, thank you,
Sir. Okay, sir. Thank you so much.
thank you,
Thank you, sir.
thank you, thank you, thank you.